Okay, we're starting subjective refraction. Basically, I'm starting monocular subjective refraction. It's monocular, okay? Not binocular. Binocular subjective refraction will definitely start after monocular subjective refraction. So, in this presentation, monocular subjective refraction, we cover only two things, that is starting point and the control of accommodation, okay? And as I previously discussed, what is subjective refraction? Subjective method of determining the most suitable lens to be prescribed with the help of subjective response of the patient. Okay, in objective there is no subjective response of the patient is used in case of objective refraction, but subjective refraction definitely subjective help is used. And the Polosky said what, it is a comparing of one lens against another using changing the vision criteria and arrived at a dioptric lens combination, that is sphere plus cylinder, which results in the maximum visual acuity. That's what Polosky in 1991 told us about the subjective refraction. So purpose is always, as I have emphasized in the previous video, is strongest plus or weakest minus. Why? Because it stabilizes the accommodation. So it creates least stress on the accommodation system. That's why it's strongest plus or the weakest minus. The both are same in terms of optics, isn't it? Strongest plus means the weakest minus means the strongest plus, isn't it? So which allow the patient for the obtain possible best visual acuity with least amount of stress in accommodation. Okay, so basically principle is to determine the combination of sphere and cylinder lenses artificially places the far point of the eye at infinity. I have already told you, I think maybe 4 or 5 times in my previous video, what is the principle of subjective refraction. Okay, in this combination of the lens provide the visual acuity with accommodation relax, least stress in the accommodation system. Okay, so type is basically, so in subjective refraction there is two types, monocular and binocular subjective refraction. I will talk about binocular subjective refraction after finishing the monocular subjective refraction. In this case, I'm again telling you, monocular subjective refraction is done when another eye is occlude. There is another eye is completely occlude. Only one eye is tested. That's a monocular subjective refraction. Binocular subjective refraction is quite tricky. See, testing eye is only one eye, but performed when both eyes being single target. It means both eye are opened, none of eye is occluded, but only one eye is tested. That's quite tricky of binocular subjective refraction. We will definitely talk about binocular subjective refraction a lot when we come to binocular subjective refraction. Okay. So monocular subjective refraction has at least 5 to 6 steps. That's very important. Okay, starting point and control of accommodation is our topic for today, and we will definitely go to monocular best sphere, and we will definitely take few more videos in testing under fog and testing without fog, definitely GCC and all these things. Fifth in monocular is spherical endpoint. 7 is spherical equalization. We will definitely talk. We'll take time. We will go slowly. Okay. So today, number first and second. Okay. So let's talk about starting point. Where do we start our subjective refraction? The very first point you must understand is objective refraction is always the starting point of subjective refraction. See, what's the significance of objective refraction? Yes, there are others. Definitely, we have to admit that there are other significance too. But the main significance of objective refraction, is to start subjective refraction, isn't it? So the starting point of subjective refraction is always objective refraction. The more better objective refraction we have, the better subjective refraction we have. And the starting point of the subjective refraction is correct, then it takes few it takes a few minutes to come to the conclusion of subjective refraction, which is very very efficient in case of time protection of our time. Okay, so one is objective refraction. Definitely it's another cycloplegic refraction after 3 or 4 days if we use cycloplegic, some cyclopentolate or homatropine, or definitely atropine is way stronger, isn't it, after 14 days. And the habitual spectacle correction or result of the previous subjective refraction, it can be another possibility that if you have if your patient has a spectacle, then that spectacle power can be the starting point of the subjective refraction. And if your patient have a report like subjective refraction of the previous visit or anything, then you can again think of a starting point. the the first starting point is always you think objective refraction. Objective refraction is that starting point. Second, psychophysical refraction, it's also part of objective refraction, isn't it? But this is another thing, that habitual spectacle correction, if he has a spectacle, or subjective refraction, value of subjective refraction you have from previous record, then it can be a starting point. Okay. Okay, understand what is the starting point and how will we start. Sometimes the only choice on availability of retinoscope is auto refraction. If we don't have retinoscope and auto refraction, then what we will do? Then other accurate refining when objective retinoscopy is inaccurate, then media opacity, keratoconus, oblique, regular astigmatism, there are other things can be have, isn't objective retinoscopy is inaccurate. So in that case, media opacity can be there, keratoconus can be there, oblique or irregular astigmatism can be there, and at that point we can use something like keratometry. We can use um, sorry, not auto refraction, we can use corneal topography, isn't it? At that condition, corneal topography can give you hints for the subjective refraction. Isn't it possible? It's completely possible. Yeah, sometimes we have to rely on other things because of the corneal problem. Okay, so these things we must take care. We must take care. So we must take, and many of times we don't take care of these things, isn't it? Geometrical center of lens aperture align with the center of entrance pupil, isn't it? That's very important. That means the adjustment of IPD, even in phoropter or trial lenses. An appropriate vortex distance is very important, very much easy with the trial frame than phoropter, isn't it? An appropriate pentoscopic angle, this is very much easier. And these all things are easier with the trial frame than phoropter. But yes, definitely we can adjust these things with the phoropter too, but it's more easier with the. And one thing you must remember, these all things are important when we have refractive error, high refractive error. But let's take example of 0.5 minus or minus 1 or minus 2. These things uh, are not that much of important or not that much of significant. Okay, doing keeping these things in your mind is very important when doing refraction. But whenever you have, like, let's take an example, apply minus 10 diopter or plus 10 diopter, my goodness, they are very important. Okay, they are very important to adjust IPD, vortex distance, pantoscopic tilt, if there is anything. So whenever high refractive error, it's very important, especially very important whenever high refractive error is cylindrical. Okay, so what is the idea of a starting point? The basic idea is to imitate the vortex distance, pentoscopic angle, angle of phase form, definitely, while presenting in the refractive prescription, when producing the form of a spectacle that is optimally fitting the patient face. So we are definitely imitating it. We are definitely copying it. So basically, vortex distance, pentoscopic angle, phase form, to that spectacle frame the patient supposed to wear, isn't it? So especially concept is high emetropia and especially high astigmatism. Correction takes place optical center entrance pupil. It's very proper subjective refraction. For very proper subjective refraction, especially in case of high metropia and high astigmatism, it's important that you see these four things. Okay. Okay, so now come to the control of accommodation. This is very important because it emphasizes, since ophthalmic asthenopia is largely caused due to the overactivation of ciliary muscles contraction. Whenever ciliary muscles contraction, accommodation happen, and because of the accommodation, we know that asthenopia, the over accommodation is the cause of asthenopia. So refractive status is represented by the focal position of eye relative to outer limiting membrane of the retina with accommodation is rest. We want what? We want focal point of our eye, secondary focal point of our eye at outer limiting membrane of the retina with what? With accommodation is at rest. That's why I have already told you that high plus and low minus, minimum minus. These things also causes the accommodation at rest. Okay. So, sorry. So, what are the two things that we can do as keeping accommodation as passive as possible? Cycloplegic, definitely through dogs and fogging technique. Okay, cycloplegics, it's basically common. It directly name itself cyclo ciliary muscles plagia paralysis. It means basically paralysis of accommodation. The advantage of cycloplegia is in cases of active accommodation spasm, in case of latent hyperopia, in case of definitely if accommodation is too strong, convergence stabs due to the accommodation. So accommodative uh, isotropia. These all cases, cycloplegia works very strongly. This condition tends to resist outline techniques such as accommodation relaxation. So these strong conditions, they need cycloplegic drugs, and I think cyclopentolate works fantastic. And sometimes, very few cases, we need atropine. And nowadays, we don't use atropine as often as the previous days. Yes. So, however, cycloplegia also inhibit the normal ciliary tone and the subjective refraction done by reducing that amount of normal tone. So, whenever we do this cycloplegic refraction, then we need to reduce the amount of normal tonus because we want normal tonus to be there, isn't it? So, we have to be cautious, isn't it? That's a simple point you will learn whenever you join your practice or you get to internship or whatever. You have to understand this point, the difference between weight refraction and the dye refraction, and the difference between doing subjective refraction, having normal dry refraction, or having the value of weight refraction. There is a two different things. If we have weight refraction value, you must reduce the amount of normal tonus, isn't it? So second technique that is very important is fogging. What is fogging? Okay, the accommodation activity is best controlled by placing focus of the distance target in front of retina, that is making eye artificially myopic. Fogging means making eye artificially myopic. See, just let me draw one thing. So this is our eye, and let's take consider the example of simple hyperopia. This one meridian and this one meridian. What if I place plus power so strong that these two focus comes here, now this and this. Okay, consider your patient can accommodate. Now in this condition, putting high plus in front of eye, definitely making it myopic. Now patient try to accommodate. What happens to this two focal point? It comes more and more anteriorly. And what happens, what is the meaning more and more anteriorly? Then meaning the blur circle becomes more and more larger. The patient see more and more and more blurred. So patient do not accommodate in this condition. But what if I remove this thing, and this is the simple compound hyperopia? The patient is tending to accommodate more and bring this to focus away from the retina towards the retina, isn't it? It's possible in case of hyperopia, but it's not possible in case of myopia. That's why that's why we put larger plus lens in front of our eye, so that we can make it artificially myopic, because we know myopic eyes cannot do not definitely not cannot do not want to bring that focal point even further closer towards the lens, even further away from the retina, isn't it? That's what fogging basically means, making eye artificially myopic. So active accommodation system moves focus towards and further towards forward and further from the eye, and vision deteriorates, isn't it? And this is retina. If it move, this focal point move from here to here, the vision becomes more and more blurred, isn't it? So optimum vision is only attainable by moving the focus towards the retina by interchanging the lens while accommodation remains inactive. So that means it means unfogging. Fogging means making it more myopic, isn't it? Making it more myopic if we make this focal point such, and if you move this focal point towards this, isn't it? From this there to this, closer to the retina, then at that case the more and more clear vision we get, and that's called unfogging. Fogging means bringing focal to away from the retina, and unfogging means bringing back that focal point towards the retina, isn't it? So procedure of fogging begin with the objective finding and add spherical plus power until patient reports distance vision becomes progressively worse. See, you have for fogging, it's always begin with the objective finding. Means whatever objective finding you have, whatever sphere and whatever cylinder you put there, okay? Whatever sphere, whatever seal you put there, and then after you add spherical plus, not cylinder, just remember it's spherical plus, until patient reports distance vision becomes blur. I think it should be 630 to 660, oh sorry, 636, okay? So optimal fogging, the visual acuity range from 630 to 636 for the eye capable of 66. If eye is capable of 66, then we fog until 630 or 636. So determines the refractive status under reasonable habitual physiological circumstances and provide refractive correction that falls within the tolerable limit of worry. So we basically do fogging means worsening the vision. For hyperopia or compound hyperopic astigmatism, add sufficient plus to ensure both primary meridians focuses in front of retina. That's important point. Just remember this. If in case of compound hyperopia, that means both the meridian is away from the retina, you have to put such a strong such a strong plus so that the both meridian, not just this meridian, also this meridian, both meridian are inside of the retina. Okay, that's very important. In front of the retina, that's very important. That's very important. Okay, for myopia or compound myopic astigmatism, both meridian are already in front of the retina. High minus, a high myopia, high minus may be added, -7, but the weaker than the any meridian. It means, let me explain. If it is high myopic, let's take example, compound myopic, it's such a high myopic, then you have to add minus to do fog, but not, don't put so much of minus so that this becomes this and it becomes hyperopic. That's not fogging. Just put a little bit minus so it moves somewhere here, not exactly at the retina but in front of the retina, but so that vision becomes 636 to 630 whatever, but don't push so much of minus so that it becomes hyperopic. That's not the concept, okay? What is the concept? The concept is, if high myopia, minus lens may be added, may be added, but weaker than that of any meridian. Don't push so much that it becomes uh, emmetropic or even hyperopic. That's the concept. Okay. For missed astigmatism, wow, this is the concept. Plus lens is sufficient distance to place the focal hyperopic meridian in front of the retina. Means in mixed astigmatism means one meridian is in front of the retina and another meridian is, one meridian is myopic, one other meridian is hyperopic. Basically, that's the concept. And just put the plus lens so that this meridian come to in front of the retina. Basically means becomes this. Okay, this becomes this, so that the hyperopic meridian comes in front of the retina. That's the concept. Okay. So classic fogging technique is, fogging is applied to the uncorrected eye in classical technique. Okay, not the initial objective to blur the eye sufficient plus reduce the minus to reduce visual acuity up to 636 or worse, and reduce plus power, add minus length in a 0.2 steps until visual acuity improved and that patient can distinguish line, card, distinguish astigmatic correction or unfogging. So unfogging you have to do slowly by 0.25 steps. Okay. In hyperopia, distance visual acuity not released or even improves with a plus lens. So in hyperopia, it's quite tricky. Whenever you are doing fogging in hyperopia, the chances gets the visual acuity gets better. There is chances. So you have to be cautious whenever doing fogging in case of hyperopia. In such cases, progressively strong plus lenses are placed until the visual acuity blurs appropriately this. So in case of hyperopia, whenever you put plus lenses, the chances there may be the chance of visual acuity getting better, but you are not going to stop there. You are just going to putting plus 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 until visual acuity actually get worse up to 636. That's the good point where actually uh, it means that the case is fogged completely. Okay, in myopia, distance vision blurs with a small plus lens, uh, and prior estimation of the type of refractive error can be done by observing on a visual acuity and near acuity. So these are the case of these are prior estimation we already did, and prior estimation, but it's these are the classic fogging technique is another technique they mentioned in the boards, but it's always better first to correct the lens eye with the objective refraction, and then correct the eye, not just correct the eye with the sphere but correct the eye with a cylinder too, and correct the eye sphere or cylinder by objective refraction. That's why objective refraction is so important, the correct objective refraction. And then you go slowly on fogging and another thing. So it's always important to do fogging with the correct subjective refraction, then go uh, one corrector. So prior estimation of the type of refractor can be done observing on a visual acuity and near acuity, isn't it? So let's take an example. Distance visual acuity is 660 and near visual acuity is n4. Isn't it myopic? So distance visual acuity is 6. Let's take a 12 and near visual acuity is n18. Isn't it like hyperopic, moderate to severe hyperopic? So sometimes we can prior estimate the refractive error, gross estimation, but not always. Okay, so it's far important for controlling accommodation, and always remember starting point is not about just this objective refraction, it's about pentoscopic tilt and understanding your trial frame and matching IPD with the trial frame's IPD. It's central important. And whenever you talk about control of accommodation, you talk about cycloplegic refraction, and always understand advantage and disadvantage of cycloplegic refraction. And then fogging, always understand fogging, the starting point which to correct the refractive error, and then put plus, so that two focal points, both of them comes in front of the retina, and so that patient cannot accommodate more, and if they accommodate more there will be more myopic, so they choose not to accommodate. So that's the concept of starting point and the control of accommodation. Yes, definitely this is the central book which is clinical refraction of all time, and I have already also used this primary care of optometry by Theodore Grosvenor, and definitely this is a golden book in case of clinical procedure in optometry by Amos. So these are the three references. Okay, I think I'm going to continue the presentation uh, in another video. Okay, bis dann, tschüss.